Good morning, everybody. Welcome to the Australian Dementia Network Registry. We're going to launch the 2024 annual report. I'm Henry Brodati, and I co-chair the ADNeT Registry Steering Committee with Stephanie Ward. I work at the Centre for Healthy Brain Ageing at UNSW. I'd like to acknowledge, and the Australian Dementia Network would like to acknowledge, the traditional custodians of country throughout Australia and their continuing connections to land, sea, and community. We pay our respects to all Aboriginal and Torres Strait Islander peoples, their culture, and to their elders past and present. The ADNeT Registry would like to acknowledge support, the funding received from the Australian Government Department of Health, Disability and Ageing under the National Clinical Quality Registry Program. The ADNeT Registry is part of the broader ADNeT initiative. The steering committee is co-chaired by Stephanie Ward and myself. Stephanie also is the clinical lead, and the academic lead is Professor Susanna Ahern. The registry is managed by Monash University, but look at the large number of partners that we have. We have many universities all around Australia in every state, and the registry does spread across the country. So the speakers today will be Chris Rowe, who I'll introduce in a moment, Stephanie Ward, Lauren Priest from the Flinders Medical Centre, Associate Professor Paul Yates from the Austin Health and the University of Melbourne, Jenny Webb from the Australian Institute of Health and Welfare, and Professor Sharon Naismith from the University of Sydney. We will have a Q&A session. Please use the Q&A button, which you'll see at the bottom right-hand corner, almost at the corner, of your screen. And these questions will be answered during the Q&A session at the end of the webinar. I learned a new word in preparing this, upvote. It means prioritize, but I thought it was such an ugly word, but in fact, it's a real word. You can upvote a question by clicking the thumbs up icon next to it. So if you think it's a really great question and you would like it answered, click on your thumbs up. So Chris Rowe is a nuclear medicine physician and neurologist with over 20 years' experience in dementia research and patient care. He's the inaugural director of the Australian Dementia Network, and he's Director of Molecular Imaging Research at Austin Health in Melbourne. He's a professorial fellow at the University of Melbourne and an NHMRC practitioner fellow. Chris, over to you.
Thank you, Henry. Can I have the first slide? So I'm just going to give a bit of an overview of ADNeT, of which the CQR is basically the jewel in the crown, but there'll be plenty of other speakers covering the details of the Clinical Quality Registry. But ADNeT was set up back in 2019 with three main aims, and that was to establish a dementia clinical quality registry, to establish best practice guidelines for dementia diagnosis and treatment, and to facilitate development of effective therapies by screening people and getting more people into clinical trials. And ADNeT is a unique community of Australia's leading researchers for dementia diagnosis, treatment and prevention. And it's fairly unique in Australia to have such a network in a particular area of medical research. Next slide. So I'll skip the CQR and go straight to the memory clinics. So the memory clinic guidelines were published in December 2021 by ADNeT. They were revised in 2023 to include culturally and linguistically different populations and also persons with intellectual disability. And we've also undertaken a guidelines monitoring and quality improvement pilot program. So these guidelines have been well distributed and have been widely used and accepted. Next slide. We also created a national map of memory clinics, basically a click and find a clinical service in your region. This is published on the ADNeT website. It includes 157 services and it contains all the details about those services. So this is a great aid for both patients, families and GPs and other doctors wishing to find memory specialist services. Next slide. We've undertaken considerable educational activities, providing clinician peer support, various resources, a lot of training. We've done over 15 webinars with over 3,000 registrants. We've got YouTube videos that have been viewed by over 50,000 people. We've also created tools to assist neuropsychologists. Next slide. We've been screening around Australia. We set up centres in most of the major cities and also in Newcastle. And at these sites, people referred for investigation and suitability for trials undergo cognitive testing, amyloid and tau PET scan imaging, MRI. Some who volunteer have cerebrospinal fluid, and they all have a lot of blood collected for research. And all this data is available to help researchers investigate the causes and diagnostics and develop treatments for Alzheimer's disease and other dementias. New slide. In fact, we fully screened through this process 1,600 persons, and many of them were referred on and have been now participating in clinical trials. We also had a research volunteer portal on our website, and we have over, I think, 4,000 people now registered who are interested in supporting dementia research. Next slide. We're now running studies in general practice, looking at the impact of the new emerging blood biomarker tests for AD. So far, we've put 230 GPs through an educational program. 102 of those have signed on to actually use the blood test in their clinical practice. At the moment, this study is limited to Adelaide, Newcastle and Melbourne. And to date, we have 135 GP patients who've had the plasma p-tau217 assay. We've recently had the funding extended through support from commercial companies, initially funded from the Department of Health. But such interest in this study that we're actually getting lots of expressions of interest in funding coming forward. Next slide. Virtual memory clinics. I'm going to leave this to Sharon to discuss later on, so please skip through this slide. We are undertaking cognitive intervention for patients with mild cognitive impairment implementation research, and this is being done through Deakin University, Griffith University and the University of Sydney. Skip through this one. And ADNeT undertakes, no, we went one too far. So we have established a leading presence in Australian health and the research community. We lead the Australian Dementia Research Forum, and the next one's coming up in Sydney in June, as shown here. ADNeT is also home to many special interest groups and to the early and mid-career dementia researchers interest group. And that's the end of my quick presentation. We'll skip this slide. I've run out of time. Thank you.
Thank you, Chris. That was a great overview. And I'm really excited to now speak about the ADNeT Registry 2024 annual report. So my name is Dr. Stephanie Ward. I've been a senior research fellow at the Centre for Healthy Brain Ageing, along with the amazing, one of my heroes, Professor Henry Brodades. But I'm also a clinician, I'm a geriatrician. And that's where my interest in clinical quality registries began, because clinical quality registries, they're all about harnessing data to allow clinicians like me the opportunity to objectively reflect on what treatments and processes of care we're providing and look for ways to do things better. And launching the annual report is, hold on. I'm going to work out how the slides moving. It's a really wonderful moment because it is the culmination of collaborative efforts representing a really broad community of stakeholders involved in dementia. So this report reflects the efforts of clinicians around the country who participate. It reflects the contributions of our many varied members of our steering committee, and it also reflects the efforts of people with lived experience who have had input into how we have designed and governed this registry. The annual report is available today on a website, which we'll have the address for soon, and it's sorry, I'm not very good with these slides. It's my privilege to now share with you some of the key findings. So in 2024, we had over 2,600 new participants, representing nearly 7,000 participants since the registry commenced. In 2024, we had 74 clinical sites from around the country contributing data. Most of these were from memory clinics, but some were from private independent specialist practice. Our participating sites are sites which diagnose cognitive disorders such as mild cognitive impairment and dementia. In our registry in 2024, approximately 1/3 of our participants had been given a diagnosis of mild cognitive impairment, and around 2/3 had been given a diagnosis of dementia. With Alzheimer's disease, mixed Alzheimer's and vascular disease and vascular dementia being the top 3 subtypes of dementia that is being diagnosed in clinics around Australia. In terms of our demographics, the median age of mild cognitive impairment in Australian clinical settings is 77 years and 79 years for those diagnosed with dementia. There is a slight predominance of women compared to men. People from First Nations comprise about 2% of our registry participants, and over 1/3 of participants in the Australian Dementia Network Registry were born outside of Australia, and around 10% prefer to speak a language other than English at home. We collect metrics on people's level of cognitive function at the time of diagnosis. And that's a really high-level measure of how early we're capturing dementia diagnoses across the country. And the scores reflected in this diagram here are consistent with registries from other countries, for example, Sweden. We also capture important information about people's level of function, as well as comorbidities such as falls as part of the registry. And our data shows that, for example, falls have occurred in around 1/3 of our participants in the last year of before diagnosis. We also collect information about risk factors for dementia, including potentially modifiable risk factors. And we find that, like other cohorts, the cardiovascular risk factors are particularly common, especially hypertension in people newly diagnosed with dementia or mild cognitive impairment, representing important opportunities at a public health level to institute preventative measures. We also importantly collect and report on basic aspects of diagnostic workup so that clinicians can reflect upon the clinical processes that they're implementing and how this compares to other sites. Of note, you can see that up until now, there's been very infrequent use of biomarkers in the diagnosis of dementia. This is a metric that we anticipate is about to change with the new availability of disease-modifying therapies such as monoclonal antibodies. We collect information on important psychotropic medication use and neuropsychiatric symptoms present at the time of diagnosis. And I'm excited that we now measure how often we're referring people newly diagnosed with dementia to important post-diagnostic supports. And finally, we collect information on people's individual experience of their diagnosis and their clinical care, as well as their well-being. And this is using co-designed surveys, co-designed with people with lived experience. And such metrics that we include in this measure include whether people felt that they were given enough information when they were diagnosed, and whether they felt empowered with enough information about where to go for help next. We'll be sharing this slide at the end of the session, but I'm putting it up again. This is how you can access a report. And you can also just Google ADNeT Registry Annual Report 2024, and hopefully this link will come up. But we're very, very proud to be sharing it with you. So I'm going to finish my talk for now. And I'm very pleased to, just try to move to the next slide, perhaps someone else could move to the next slide, introduce Dr. Lauren Priest. She's a geriatrician and the clinical lead of a memory trials unit at Flinders Medical Centre in Southern Adelaide. Her special interest is in dementia from diagnosis and clinical trials through to behavioural and psychological symptoms of dementia, as well as the end-of-life care. Thank you, Lauren, for sharing your experience of participating in the registry.
Thanks for the introduction, Stephanie, and thanks for having me today. So yes, I am based in Southern Adelaide in the local health network there, and based out of Flinders Medical Centre. Just some disclosures that, like Stephanie said, I'm the principal investigator for our memory trials unit. And I've been asked to come and speak today about a quality improvement program that we did based off our ADNeT site-specific data. So Flinders Medical Centre is about 20-ish minutes south of the Adelaide CBD. We have 4 days of clinics run each week, memory clinic, and then we also have aged care clinics. It would be over 90% referrals are due to memory impairment as well. And our clinics see approximately 1,500 patients and appointments throughout a year. So quite busy clinics for us. In April and October, through the 6-month data back in 2023, we did note that we were not quite up to par with how well we were doing with referring people with new diagnosis of dementia to post-diagnostic programs. Stephanie mentioned just in her previous slides that the average for ADNeT that year was 56%, and we were a bit behind on 26%. So we thought that this would be a good little project to try and improve how we could provide post-diagnostic support to our patients. I reflected with my colleagues about why we weren't quite so good at this, and we reflected that a lot of it's around time, and that giving someone a diagnosis of dementia, that can take time in a clinic appointment. It can take a lot of kind of discussing about it and understanding and accepting the diagnosis. And we also struggled with time from the point of view of having important other topics to talk about, such as driving or my aged care and how to access home supports. So a lot of time and competing priorities to be able to then have the discussion about ADNeT and Dementia Australia support. Sorry, make sure I didn't skip a slide there. Lovely. So our QI project, we ran from April to September in 2024 for 6 months. And what we did is we had a nurse practitioner who worked with our in geriatric medicine with us, and we had her join us in the clinics one afternoon a week. And she would provide a phone call to our people that were just recently diagnosed with dementia or mild cognitive impairment. She would then have a discussion, it was quite handy. She would answer any questions they may have had in the last couple of weeks since they saw the geriatrician or the registrar or the training junior doctor, and also be able to identify any other community supports they might need. During this phone call, she also would gain consent for completing the ADNeT registry data form, and then would also gain consent about referring the person onto Dementia Australia's post-diagnostic support program. And hopefully the outcome was we were going to see an improvement in our numbers. So how it happened was our patients would be seen in clinic by the geriatricians or the registrars. And on our little slip at the end of clinic, the geriatrician could tick a box that would say, refer to the ADNeT nurse clinic. This was a telephone clinic, and as I said, one afternoon a week. Over the six-month period, there were 19 of these nurse practitioner telephone clinics, with approximately 1 to 7 patients booked per clinic. Of those that she had booked into her clinic, 73% had a dementia diagnosis, and 27% had a diagnosis of mild cognitive impairment. And we had kind of similar demographics actually to what Stephanie presented with the overall ADNeT data, in that we had a slightly female preponderance, and Alzheimer's and mixed dementia were our most common subtypes of dementia. So you'll see here in the graphs that we fortunately had an improvement in our, first of all, people consenting to the ADNeT registry data, and secondly, consenting to the Dementia Australia referral, which was for the post-diagnostic support program. We improved from 44% from 26 up to 70% in terms of people accepting referrals. 30% of these people still did decline, the most common reason being people felt that they were okay at the time and didn't need the support, or some people were still coming to terms with their dementia diagnosis. And with these people, it was quite handy that we were able to then give them the information, both over the phone and submission information, about how they could in future contact Dementia Australia for support. So we found that having a specific geriatric skilled nurse in our memory and aged care clinics did enhance our overall follow-up and referral pathways. And this ensured that our patients in Southern Adelaide did receive a more timely referral to post-diagnostic support to be able to be completed with Dementia Australia. And we also just demonstrated how useful this data was at our site to be able to drive some local targeted change for our patients with dementia. Thank you for that, Stephanie.
Thank you so much, Lauren, for a really great example of how registry data can be used to drive changes right in the clinic setting. So that's brilliant. I'm just going to briefly mention that 2024 and now 2025 has been a really big time for us in the registry, because there has now been the approval of new medications for Alzheimer's disease monoclonal antibody therapy. And a really important role of clinical quality registries is monitoring of the uptake, the safety and effectiveness of new treatments to provide really important real-world data. So the registry team worked very hard in 2024 to develop a new module. And we wanted to develop a module of data to collect for people started on these therapies and incorporate some flexibility, noting that some of our existing sites were in a position to start prescribing, and noting that some sites are not participating in the registry to date, but really wanted to collect this data on its own. We developed a data set that captures important information, including some relative contraindications, medications, diagnosis, which has to be Alzheimer's disease, and cognitive status at the beginning or prior to therapy, as well as important demographic variables. And we also developed follow-up data, which includes options to track important side effects that can emerge from new therapies, and as well measures of potential efficacy. Well, we know that these medications have been shown to be effective in clinical trials, so we're measuring cognitive function, neuropsychiatric symptoms, and daily function to allow us that really important real-world monitoring. And so on that note, it gives me great pleasure to introduce a fellow geriatrician, esteemed geriatrician, Associate Professor Paul Yates, to speak about the ADNeT Novel Dementia Therapies Community of Practice. Paul's a geriatrician with expertise in dementia in hospital and community settings, including residential aged care. He's a director of Cognitive Dementia and Memory Service, as well as a director of research for continuing care at Austin Health. And he's a clinical associate professor with the Department of Medicine, Austin Health University of Melbourne. Paul serves on the Dementia Australia Research Foundation Scientific Panel, the ANZ SGM Scientific Advisory Committee, Steering Committee of the Melbourne Ageing Research Collaborative, and he is the clinical lead for this new community of practice. Paul, thank you for sharing your experience with the community of practice with us today.
Thank you, Stephanie, and thanks everyone for having me, and thanks to the team for progressing the slides. So yes, I'm excited to talk about the somewhat unwieldingly named Australian Dementia Network Novel Dementia Therapies Community of Practice. Next slide. All right, 1 second, this looks like it might be the wrong slide, but keep going, another slide. All right, there we go. Okay, so this is the culmination of a lot of discussion as these new dementia therapies were emerging and showing promise in trials, and then subsequently were released in the real world. A lot of us involved in memory disorders clinics and research were discussing that there was a gap in clinician awareness and comfort with understanding these new treatments. And so we thought it would be a good idea to work together to build, I guess, our practice and capacity to introduce these new therapies. A lot of things involved in, say, for example, donanemab, lecanemab, were very foreign to most memory disorders clinicians. Things like providing infusion-based treatments and the types of interventions. If we weren't involved in trials, they are quite different as an intervention from what we generally have done. So we initially began quite organically and then banded together to increase our membership. And it's been auspiced by ADNeT, which is fantastic because it's a great way to sort of broaden the reach of ADNeT as well. So in general, we aim to provide an open community of practice for clinicians who are interested in providing new therapies, but also new access to new diagnostics and other non-pharmacological evidence-based interventions as well. We really want diversity of representation across different settings, particularly for regional or remote. Can you not progress that one yet? and share information. Okay, next slide. So these are our listed specific objectives, as well as providing, I guess, a community of practice. We wanted to be able to identify knowledge and practice gaps, to provide a forum for developing advocacy, to raise awareness of issues, and also to support important post-marketing sort of safety surveillance for new treatments, such as the ADNeT monoclonals registry. And we wanted, as I said, a broad membership to link with all of our collaborators and have as much representation from key stakeholder groups, including the societies listed here. Next slide, thanks. So we have, happily, we have a diverse membership of many different types of specialists and clinicians. As I said, we have established representation from our craft groups and key societies that we'd hoped to. We do have metropolitan and rural and regional representation. We'd still like to work on getting more ATSI and remote sort of support. And we have run a number of surveys to engage our membership about our priorities. So we specify that it's not open to pharma to join, but certainly we interface and engage with pharma to make sure that we're across what's topical and developing. Next slide, please. So we have a set structured agenda. We cover off in our meetings therapeutics, non-pharmacological therapies, investigations, and then things like education, resources and research, and engagement and advocacy as well. Thank you. Next slide, yeah. In terms of gaps that have been identified in our membership, so obviously people weren't familiar with giving infusions and managing their safety, for example. So we've disseminated information about this, developing consumer-facing materials for people considering monoclonal antibody therapies, clinician support and patient information about discussions around ApoE for genotype disclosure, how best to educate and access the newer Alzheimer's biomarkers, generally peer support in patient selection, and also identifying who's prescribing and administering where to link people if they're not themselves prescribing to pass their patients on. Next slide. So I've said over 100 members. We've actually got 266 members of the community of practice, which is incredible, really a great degree of interest. We've held 8 meetings to date since we began, and we've got specific working groups established to work on things like genetics and also access and advocacy. Members have drafted an opinion piece for submission to a newspaper. It's drafted and it's being shared amongst the membership at the moment. We've got engagement from the Centre for Genetics Education to develop a webinar and also revising the ApoE fact sheet for consumers. And we've got a resource repository as well, a Dropbox for members to share and also look through what people have shared in terms of common resources that might be helpful. And these are both education resources, but also things like local protocols for people that are happy to share and standard operating procedures, so that we don't all have to reinvent the wheel if someone's created a good document. Next slide. This is my last slide. If anyone has any interest or wants to learn more, please reach out. This is our email address. And thank you so much to all of the ADNeT team for their assistance with this, especially Lara, who manages my level of disorganisation very well. Thanks so much.
Thank you so much, Paul. The community of practice has been such an important development in the dementia treatment landscape in Australia. And I think it also really speaks to the heart of what ADNeT does, which is bring us together as a community. Because here we are talking with neurologists and geriatricians. And by the way, a lot of us never used to talk to each other. Psychiatrists, GPs, people with lived experience, researchers, policymakers. I think the community of practice, as well as a registry, it really shows us what ADNeT's about. It's about bringing us all together to translate things quickly, to make a difference and to support each other as we deal with these big challenges facing our Australian community and healthcare setting. So it's now my great pleasure to introduce to everybody Ms. Jenny Webb. Ms. Webb is a project manager and a senior analyst in the Dementia Data and Reporting Unit of the Australian Institute of Health and Welfare, the AIHW. She's the project manager for the National Dementia Action Plan Indicators Dashboard, which is quite a big undertaking. And she has a Bachelor of Science in Statistics and 30 years of experience in data analysis, data development, performance indicator design, reporting, and sample design. At the AIHW, Ms. Webb has been the lead project manager and data analyst for the development and reporting of performance indicators for the National Disability Agreement and various indicators for the National Healthcare Agreement. Thank you, Jenny.
Thank you. The Australian Institute of Health and Welfare's National Centre for Monitoring Dementia was established in 2021 to monitor dementia, improve dementia data, and inform dementia policies. All of our work is funded by the Commonwealth Department of Health, Disability and Ageing. I'd like to highlight 2 aspects of our work where the ADNeT Registry have supplied data. Next slide, please. You're probably aware that in partnership with state and territory governments, the Australian government has developed the National Dementia Action Plan in response to the growing impact of dementia on individuals, families, and the healthcare system, and also to address recommendations from the Royal Commission into aged care quality and safety. The vision of the plan is stated on the slide. The action plan has 8 actions that cover what is needed to achieve this vision. Next slide, please. Under each action are statements called measures of progress that outline how it will be determined whether the action plan is meeting its objective to improve the lives of people living with dementia and their families and carers. Overall, there are a total of 45 measures of progress for the 8 actions. Next slide, please. The AIHW develops and reports on indicators to track change over time for the measures of progress. Last December, we published the NDAP Indicators Dashboard, which contained baseline data for 50 indicators. We'll be publishing an updated baseline report in December of this year, which will include baseline data for 3 new indicators. Then there will be 53 indicators covering 31 of the 45 measures of progress. Data development is still needed to track some measures of progress where there are limited or no indicators available. In future years, the dashboard will be updated annually to assess if indicators are improving. Next slide, please. Data from the ADNeT registry have been used to report 7 indicators covering 5 measures of progress across 2 actions. 2 of the ADNeT registry source indicators are reported under Action 1, which is about equity and human rights. These indicators contribute information about people living with dementia in rural and remote areas and their access to dementia diagnosis and support. Next slide, please. The remaining 5 indicators sourced from ADNeT registry data are reported under Action 4, which is about improving dementia diagnosis and support, and in particular about increasing access to memory clinics, waiting times from referral to specialist services, waiting times from symptom onset to diagnostic services, and experience with diagnostic services. Next slide, please. To address dementia data gaps, in collaboration with the ADNeT registry, we're linking the ADNeT registry data to the National De-Identified Linkage System. Next slide, please. The National Health Data Hub is our data linkage system that draws together health, welfare, disability, and aged care data sets. Insights from the National Health Data Hub contribute to an array of reports informing government policy. You can see on this slide some of the data sets which are linked as part of the National Health Data Hub. Next slide, please. The ADNeT registry and the AIHW have worked together on ethics and data governance, and the AIHW is linking the ADNeT registry data to the National Health Data Hub for use exclusively by ADNeT analysts and the AIHW. The AIHW sees the ADNeT registry as an important national initiative that addresses current dementia data gaps and systematically collects and reports data on quality of care and patient outcomes from the time of diagnosis with dementia or mild cognitive impairment. This linkage project will answer questions about key health outcomes and service use. Next slide, please. I'd like to take this opportunity to promote the Living with Dementia survey, which is being run by the AIHW in conjunction with the University of Canberra to address other data gaps in dementia data. The survey is for people living with dementia in the community. If you are a person living with dementia or you know someone, we'd love for you to participate. The details are on this slide. Next slide, please. After this event, if you have any questions, please feel free to contact us. The email addresses are there. Thank you very much.
Thank you so much, Jenny, for that really comprehensive overview of the vital work that is taking place with respect to national dementia data and how the ADNeT data source fits into that picture. It's now my great honour to introduce Professor Sharon Naismith, who will speak to us about the evaluation of the hybrid virtual memory clinic via the ADNeT registry. Professor Naismith is a practicing clinical neuropsychologist, an NHMRC Leadership Fellow. She founded and directs the Healthy Brain Aging program at the Brain and Mind Centre. The quality and impact of her work has been recognised most recently in 2025 by an Order of Australia medal for her significant services to neuropsychology, particularly dementia. Professor Naismith also co-directs the Memory Clinics initiative of ADNeT. She's a tireless advocate for funding, for policy change, for health service transformation, to create equitable access to memory clinics, improve diagnostic and post-diagnostic support. And she's a bit of a role model for any of us who want to combine clinical and academic pathways. She's recently received MRFF funding to test the quality of a novel hybrid virtual memory clinic model for regional and rural Australians. And she's going to speak to us a little bit more about this now. Thank you so much, Sharon.
Thank you so much, Stephanie. Next slide, please. And again. Thank you so much. Before I launch into what this project's all about, I'd really like to acknowledge the wonderful leadership and input of this amazing group of investigators that have been key to the design of this study and the evaluation of the study. And in particular, I'd like to acknowledge the leadership of Lee Fei Lo, my co-lead on this project. Next slide, please. So the reason for doing this study is that we know that 34% of older Australians live in regional and rural areas, and Jenny just told you about how this is a priority to really think about increasing the quality of services that we actually provide in these areas. And unfortunately, less than 10% of Australia's memory clinics are located in regional and rural areas. And these tend to be single discipline clinics. So they're not what we would define as a gold standard multidisciplinary memory clinic. Subsequently, services tend to be very reactive, and diagnoses are much, much later. So you don't typically see the MCI diagnoses that we just heard about as being really kind of increasing and prominent in the typical memory clinic setting. There's very limited access to multidisciplinary assessments as well as post-diagnostic support. And as you can imagine, the waiting lists are very long. Oh, sorry, we have some transitions here. So if you could click, please. So what we want to do then is to test a hybrid virtual memory clinic model to increase the access to clinics and the multidisciplinary assessments. And as I said, these are key priority areas. And next slide, please. So what we aim to do was to co-design and also implement a hybrid virtual memory clinic. The reason why we call it hybrid is it's not simply a telehealth service. What we would like to do is very much run these services in combination and in partnership with the local regions, utilising their workforce, their local health district, and other people on the ground, and also link into existing things. So not to reinvent the wheel, but to very much be part of their services. And then we want to evaluate the impact of those on service quality, referrals, waitlist diagnoses, client experience, and barriers and enablers to successful implementation. If you could click, please. Thanks. And so really we have a hypothesis that we'd like to test, and that is, does provision of this kind of clinic actually produce similar quality services? We recognise that face-to-face services are always important and that there's definitely a role for those. And that's why we've incorporated that into our hybrid virtual memory clinic model. But we want to make sure that we're not providing an inferior service to people that are living in these regions. Next slide, please. So we're very, very fortunate to receive some funding for a pilot study from the Department of Health and Ageing and with support of ADNeT. And so we've conducted a pilot study in the Echuca region of Victoria. And when we launched the clinic, there was actually a 9-month waiting list in that area. Within just a few weeks, we were able to clear the waiting list that they had. And you can see from these graphs here that overall the wait times for the virtual clinics are much shorter than you might expect from the traditional service that was being run in that particular region. And actually, if you account for the fact that there was a 9-month waiting list there as well, you can imagine that the hybrid clinic offered much shorter waiting times as well. So we think this is important in trying to see people earlier, even if the diagnosis time is a little bit longer than the actual time to initial appointment. That's really important in advance to be able to see people earlier and to give a timely diagnosis in these regions. Next slide, please. The other thing is that you saw from the slides that Stephanie presented the degree of diagnostic specificity. And so this slide here compares the proportion of dementia subtypes at Echuca Health versus the memory clinic, the hybrid clinic, and also the proportion of the MCI subtype. So Echuca is in the top bars and the hybrid clinic is in the bottom bars. And from the graph that you see on the left, you'll see that the hybrid virtual memory clinic offers much more diagnostic specificity than the Echuca clinic was able to do. So we were able to look at all the different dementia subtypes, which are very, very similar to what Stephanie presented in the breakdown of the CQR data. And then you also see even within the mild cognitive impairment subgroups that there's also a lot of specificity to the cognitive profile. And this certainly helps us in planning post-diagnostic support. Next slide, please. You can also see from the slide here in the pilot study that the type of clinical diagnosis was very multidisciplinary, so in 71% of cases, and also that we used a combination of single mode, which was only in 14% of people, versus multimodal delivery. So what this means is that many people had a combination of face-to-face and virtual appointments. Next slide, please. And importantly, we also showed that the patient and carer satisfaction is high in terms of the service. So 100% reported being treated with dignity and respect. 94% of clients and 100% of carers had a positive overall experience with the clinic. 88% of clients and 100% of carers felt actively involved in decisions regarding their care. Next slide, please. So what we plan to do next is we're obviously very fortunate to have had the opportunity to pilot this clinic, and we've now received MRFF funding, nearly $3 million, to be able to implement this pilot clinic in 3 new areas. So this will be in Orange in Western New South Wales. There's a first rollout, and then it will also be in Gippsland in Victoria, as well as York in South Australia. And our aim really is to be able to work with those local services to fill their gaps. Again, we don't want to reinvent the wheel. We don't want to replace their services, but to really complement their services where they may not have existing expertise. And really a core part of this new MRFF grant is to use the Clinical Quality Registry to compare the quality of our service against A, national standards, and B, what's also being done at the regional and rural level throughout Australia. We also want to see how use of this virtual clinic may change healthcare usage and different treatments and diagnoses and uptake of post-diagnostic support. And importantly, we need to model how much this clinic costs. Does it actually cost any more than a usual memory clinic, or is it cheaper, for example, or is it more expensive? We really need this data to inform a more national rollout. And so that's the last part of our plan, is to develop a national implementation plan of how we could take this kind of model Australia-wide. Next slide, please. This is my last slide. This is really just kind of showcasing the pivotal role of the CQR. So we really want to then look at this clinic against the face-to-face national benchmark. So we're not comparing against virtual services, we're comparing against face-to-face clinics. And also we need to find some matched control regions that are equivalent in terms of demographic, remoteness, etc., and really then have some stringent criteria around how we're evaluating the quality. So that's it for my presentation. Just really like to thank the CQR for their partnership and support of this particular project. And really, this is the key outcome of our project. And I really don't think we would have received funding unless we really could benchmark how good the service is against the CQR data. So thank you.
Thank you so much, Sharon. That was a really great example of how the ADNeT registry data, which we also informally sometimes refer to as the CQR, can be used to evaluate new models of care. And we've seen a really great overview today of the different ways that people can use and groups can use ADNeT registry data to ultimately improve outcomes for people living with or at risk of dementia, as well as their caregivers, whether that's a clinician who is drilling down into what they're doing and reflecting and looking at opportunities to improve, whether that's at a service level, whether that's in the evaluation of and supporting the development of new services like the virtual memory clinics, whether it is in continuing to develop that important community of clinicians, people with lived experience and researchers as we grapple with a lot of the challenges at our health service level. So it's time now for some questions and answers. So I'm going to ask my colleagues who've been speaking this morning to unmute themselves and be on the ready to answer some of the excellent questions which are here in the chat. And I might call some of you out to answer some of these questions, but we've got a really important question here around what the role GPs can play in the diagnosis of mild cognitive impairment and the assessment and diagnostics that can be initiated in primary care. A lot of people have difficulties accessing specialists in this area. Could I perhaps ask you, Sharon, to speak to the role that GPs can play in the diagnosis of mild cognitive impairment?
Sure. I mean, I think it's going to be easier and easier for GPs to diagnose mild cognitive impairment as our diagnostics get better and better. I think importantly, GPs can have a conversation with someone about cognition, and as Chris said, that there will be developments. We're testing really the role of these new blood-based biomarkers. So I think GPs play a pivotal role in really trying to understand, you know, the degree of someone's cognitive impairment, to use cognitive screening tools. You know, there's the GP cog, Henry, of course, developed and is validated well for primary care, but lots of other tools. So I think that GPs are definitely, you know, best equipped as the first port of call to have these conversations.
Thanks, Sharon. Yes, Chris.
So ADNeT is heavily involved in this area. So we're working with Stephanie Daly in Adelaide and Rebecca Moore and Dimity Pond in Newcastle to look at what's required to educate GPs to improve their confidence in the diagnosis and management of patients with dementia, putting together educational programs, and then looking at the impact of access to the blood biomarkers, which one was just approved last week by the TGA, a test to exclude Alzheimer's disease. So that's a bit of a limited implication, but it could be very useful in people concerned about their memory, but there's not much to find on examination, and the GP just wants to give them a little bit more reassurance. So things are changing, and ADNeT is heavily involved in the development and upskilling of GPs. And we have confirmed that there's over a year's wait to access specialists in much of Australia through our interactions with GPs. Thank you.
Thank you for adding that, Chris. There's a couple of important questions about post-diagnostic services. Firstly, do we collect the specific details of what post-diagnostic program we're referring on to? Now, that's a great question. I'll answer that one because I'm all down with the data set. We don't collect that level of detail at this point. For every data element that we add to the registry, we have to go through the relative benefits of additional detail versus the impact of the clinician who's in a busy workload on how much time they have to enter that data. So we've just started with a broad question about whether a referral has been placed. And I've put up the results for 2024, where it was just about over 50%. But there's been a question about what is the degree definition of what is an adequate post-diagnostic support? That case coordination and key workers can be really important components of that. Do we have any guidelines around what constitutes post-diagnostic support? I might ask Professor Henry Brodati what we know about what is good post-diagnostic care and what should be happening after a diagnosis takes place.
Thank you, Stephanie. So we developed a website called forwardwithdementia.org.au, which goes through all of this, if anyone's interested. And I recommend it to all my patients. We certainly should offer the people the opportunity to discuss their diagnosis. Usually it's a very difficult time for them, and they may not actually take in the information. Mind can sort of go blank during the diagnostic interview. And coming back in 2 or 3 weeks when they've had the time to process it is very valuable. So it may not be the clinician, it may be a social worker involved in the team who has that interview. Referral to Dementia Australia is routine for us, and I think it should be for everybody. And not everybody will take it up, but they should have the opportunity as well. There are a number of programs that incorporate things like cognitive stimulation therapy. There's the University of Canberra is running one such as this. At War Memorial Hospital in Sydney, there's the iReady program. The one at the University of Canberra is called SPICE. And there's now a network of these developing. And Amy Spector is going to be coming from the UK in November to coincide with AAG. And there'll be a one-day meeting on cognitive stimulation therapy in Canberra. And you can contact Nathan DeCuna if you're interested in that. There's always medication. There's also medication, sorry, that may be considered for people with Alzheimer's, not just the monoclonal antibodies, but the routine cholinesterase inhibitors that we've been prescribing for 25 years. And there's medical legal issues, and there's driving, and there's, continuing lifestyle interventions. So there's quite a lot that we can offer in post-diagnostic care. But the point is to give people opportunity to talk and arrange follow-up, alert them to the medical legal issues.
Thank you, Henry. That's a really comprehensive answer. Paul, there's a question for you around the community of practice. Is there a place or a role for people with lived experience, for consumers, carers, and patients to be participating in the community of practice? Oh, I think you're on mute.
Sorry, I thought I'd unmuted myself. Thank you. There's always a place for consumers, I think, and if people are interested in being involved, that's wonderful. Many of us have got sort of consumers that we work with in other forums, or may also have lived experience. So I think that we all are trying to.
Medical emergency team, Ward 5 East, cardiology unit. Medical emergency team to Ward 5 East, cardiology unit.
So I think we benefit from our work with consumers, caregivers, people with lived experience. I think it's how we keep our work relevant and really meaningful. So I think it's an important aspect.
Fantastic. Thank you, Paul, and thank you for delivering that information despite the emergency that was taking place. There's another question about the fact that specialist fees are quite high, and are high out-of-pocket fees putting people off seeing a specialist? And if so, how can we expand memory clinics to provide an affordable alternative to diagnosing cognitive disorders? I might ask you that question, Sharon.
I'm not sure I know the answer to it, to be honest, but I do think that we will get better with the use of the blood tests and more training of GPs. And I think, to be perfectly honest, we do need more state and territory investment into memory clinics. Like, we are way behind international standards. Our clinics often see 3 patients a week. Internationally, they run clinics every single day. So we really need to increase the throughput. And we also really do need to support the private workforce, because they are seeing a lot of the patients that are coming forward for assessment, and they do have real costs as well. So I think we do need to find ways within the health system to make it, still feasible for them to run private practice. They often do see people quicker. The diagnostic process may still be a little bit longer, because they often then have to refer to many different kind of options. But I think that's an excellent point, Michael. We need to look at all of those models and to make it cost effective.
Thank you. Some really good discussion. So we're at time for the end of this session. Now, there are a couple of questions about the website that Henry mentioned, that's Forward with Dementia, as well as links to programs and contacts for good post-diagnostic support. And perhaps the team, in addition to sending a copy of the webinar, which you can watch at your leisure later on, we'll try and compile a list of those websites for to distribute, if possible, with the talk. So I want to thank everybody for participating today, for coming along, and I'd love to thank all of our panelists for participating in this really important milestone. I'd like to particularly acknowledge the absolutely outstanding efforts of the ADNeT Registry team, Many of us know the ADNeT Registry team, and we know how tirelessly they work around the clock with so much care, sensitivity, and dedication that, to be honest, and I often say this, but it's actually it's a true inspiration for me to work with people who are so committed. And we're in this because we really want to make a difference. This is a huge endeavor. It's complex and it's complicated, and we couldn't get to this point without your support and your input. This registry exists to improve outcomes for people living with dementia. And so we invite you to participate. We invite you to share your feedback, your ideas, because we want this to continue to grow and to deliver more and more value over time. Please make sure that you download your copy of the registry annual report, use the data, and we look forward to seeing you next year for next year's annual report.